To close this out, we're going to bring back Dr. Cummings, who's going to focus in a little bit for us on when do you make that referral and the role of the specialist in dealing with things. How do you leverage that in the most effective way? Dr. Cummings.
Thank you. So, I was kind of reflecting on everyone's sections. And I think one of the gaps that we didn't really touch on, and we can spend a little time if we have at the end, is the role of palliative care. There's a certain population, once you reach, that severe to very severe stage, where it doesn't matter what inhaler, doesn't matter what pulmonary rehab, doesn't matter what DME, oxygen, BiPAP that you give them, they're just not going to do well. Okay, and so it's a little bit of an art form to know when to refer to palliative care, but I would welcome you to start thinking about those patients that are in Gold D. Where are we? How much exercise capacity do they have? Are they losing weight? Where are we losing ground? And is there a role for palliative care? So I think that it's hugely important. I see it a lot more than you guys will, but I think it's something we need to start thinking about. So we'll start and finish with sort of COPD is a preventable disease, right? It's smoking. It's driven by smoking. It's preventable. All right, so some of this may be a little bit boring, and it might be also new to you, but how many people here love the EMR? Not many. Okay. So in a way, for a specialist and a primary provider, there's this concept of needing to turn back the clock in order to fit into a paradigm of what we would call a medical home. I know you've heard of that, or a medical neighborhood. And this is all about communication, okay? We don't know you and you don't know us. It's like you're sending a patient to a different country when you're sending them to a specialist. And when we send them back home, it's rare that we have a relationship with that primary care doc or the primary care clinic. It just is the way it is. It's the way that health systems work nowadays. So if you look at the literature, and you have a study that did a survey of about 4,700 specialists and PCPs. When asked, the PCP said 69% of the time I'm sending the adequate information to the specialist. 35% of the time the specialist says, I got it. So the majority of the time they're saying they're not getting it. When you ask the specialist says 81% of the time I'm sending my consult note and communicating my plan back to the PCP, and the PCP says 62% of the time I get it. So about 40% of the time they're saying I don't get it. So what good does it do to send a patient to a specialist if you don't know what they're going to do? Okay, so I think that just what we're talking about is enhanced modes of communication. Okay. So when we talk about ways to improve the coordination of care, it's really about 4 different concepts. 1, to develop a coordination relationship. Find the go-to person to manage referrals in both the primary care and specialty care setting. And you have to have tools to improve the communication and reporting between parties. Nowadays, it's electronic more than anything else. So I think there needs to be more of a focus there, and I know CareOregon and our clinic are making attempts. Prepare and maintain referral agreements and patient care plans. The American College of Physicians has had recommendations on just this for nearly 20 years, and rarely is it implemented. I have a slide after this one that will talk about that. Improve access to specialty care. So how do you do that? Well, you need to make sure that there's adequate space available in a specialty care clinic. Are there scheduling templates in the specialty care clinic? Another way to do this is to have care go home. And I know that Heather participates in this, and when we have severe patients, there are resilience outreach workers that CareOregon has. You can tap into. If they're that type of a patient, you can have someone visit at home. I know that in our clinic, for the last 2 years, we have block time. So there are 2 sessions, either morning 2 mornings, 2 afternoons, or morning and afternoon, that we see CareOregon patients and only CareOregon patients, and that's with one provider. So we kind of have a way to narrow this population into CS and have a guarantee that there's going to be space there. That doesn't mean that I don't have CareOregon patients outside of those blocks, but at least we have those spaces held every single week. Okay? And then expand access to information between providers, preferably electronically. As months and years go by, the way that OCHIN and EPIC communicates with other electronic medical records is improving, and I know that CareOregon and at least the Oregon Clinic are making inroads along this, but we have to be able to track communication somehow. Okay, it would be great if we all had time to pick up and answer the phone like we used to. It just doesn't happen that much. I'm not saying we don't do that, because we have someone available. So from the PCP side to the specialist side, we'd like to have a care coordination agreement. So for part of every referral, optimally, this is what the American College of Physicians says. You should have a specific clinical question, just one sentence. What is it that you're wanting the specialist to do? And in this case, what do you want the specialist to do for this patient's COPD? Okay? So you indicate a specific clinical question. How urgent is it? You know, many times in COPD, you're not going to have, I need to get them in to see you in the next 1 to 2 days, but that's also a possibility, right? So you need urgency of, it's urgent, it's subacute, 1 to 2 weeks, or, sort of dealer's choice. And usually it takes, in our clinic, probably 1 to 2 months for a non-urgent patient to get in, okay? So the referral type is, I think, where we fall down a lot. We have a couple that pre-visit advice used to basically be telephone call. And nowadays, I think I know we have methods for electronic communication between the PCP's office and the specialty care clinic, specifically Oregon Clinic, where a simple email should suffice. We are now working on a more formalized approach to non-synchronous consultation, meaning the ability for the specialist in our clinic to take a look at the patient's chart based on the question that the primary care has posed and to basically do a virtual consult. Right now, with our CareOregon COPD patients, we're reviewing that referral and then taking a look at whether or not this would be something more appropriate for a virtual consult. And so we will review things and then get some recommendations back without seeing the patient face-to-face, always with the option of seeing them face-to-face if the referring provider really wants that. And I think this is sort of a work in progress as well. And then there are some asynchronous questions that can be asked that aren't sort of linked to a specific patient, and we're working on a platform to make that a lot more available for both sides. So that's pre-visit advice and non-face-to-face. If it's a procedure, we're not going to talk about that here. So, ultimately we need to know, we just want a consult, we want recommendations regarding the management of COPD and maybe an extra visit beyond that, okay? Or we want sort of ongoing co-management with shared care. And there are a couple of levels here. One level would be, I'd like for you to kind of continue to follow longitudinally. However, we're still going to be seeing this patient for COPD back in our clinic from a primary care standpoint and managing it because we need to be managing it more often than you. Or our comfort level has now reached a point where we don't feel like we can manage this disease. And so I think for anything COPD, pulmonologists, will you please do that? But we need it spelled out because, oftentimes it's part of the art of being a specialist is when to know or how to know when to let the patient go, right? And it can be difficult. It can vary from provider to provider. But I think working towards a more standardized method or way to think about that is something that we're doing with CareOregon patients right now. Rarely do we just have full responsibility. That's usually sort of in the realm of oncology with a chronic cancer like a breast cancer or something like that. And then we always need the pertinent clinical data. What was the spirogram? What's their exacerbation history? What are their symptoms? What are their comorbidities? And that should be in sort of the referral note that we get. What do you expect from us? So, there are certain benchmarks that we should be meeting, and if we're not, then it's important for us to know, okay? So we need to reserve spaces to allow for urgent care. We have that, and it doesn't have to be a block time. We have urgent spaces every single day. So if you have a patient that you have that's calling your office and you feel like that it's going to be outside of the realm of what can be provided in primary care, feel free to call our office and we can help facilitate getting that patient in the next day or two, okay? So, where am I? Oh, notify referring primary care practice of recognized referral guidelines and inappropriate referrals. So that's part of that review of the referral itself that we might say, I don't think this patient's appropriate to be seen at all. You ask a question at the break, what kind of referrals do you hate? Do you think you shouldn't see? And some of those are part of retraining or reintroducing confidence into the primary care realm of how to deal with some of these problems that should be within their scope of practice, right? So if I see a patient that's referred for cough who's still smoking, it's probably important to kind of deal with that cough. If I see a patient that's referred for COPD that has had an exacerbation that's only on albuterol and doesn't have a long-acting inhaler prescribed, or they don't have any spirometry, those are things that maybe, in the next year or two should be done at the primary care level. If that's not working, then refer. And we'll get into that a little bit more in the next few slides. So provide adequate information in a timely manner. That's just a matter of how do you get that note and communication back to the primary care clinic. And I think, like I mentioned, as time goes on, the platforms for electronic medical records and what are called CCDs are becoming easier to get from one EMR to another EMR. And, we should always give you the specific response to the referral question and then what we're going to do about it. What we don't do a good job of when we get a patient in clinic is sort of taken over, right? So I'll see a patient and it'll be for COPD. But I also notice, they haven't had an echo and they've got signs of cor pulmonale or other signs of left heart failure, and or they've got severe sinus disease. So we're, referring to a secondary specialist. Those things need to be communicated back to the primary care. In the past, that would have been left up to the primary care, but I think as we, integrate into more of a medical neighborhood, that understanding it's okay to do that as long as the communication's there that that's happening. And correct me if I'm wrong about some of this stuff. And then we need to notify you of no-shows and cancellations, because that can be, those can be telltale signs of barriers and social barriers to getting in to see us. And we have, I can tell you, we started the block clinic 2 years ago, and our no-show rate sort of across the board for both new visits combined with follow-ups is about 25% for the Medicaid population, just Medicaid, not dual eligible. We introduced block clinics. We thought, this is going to make a huge impact because we're going to have more access and it'll be easier to get them in and that sort of stuff. But the fact is that the no-show rate for new patients and follow-ups is 25%. So I don't think the block clinic addressed those barriers. So that's sort of an ongoing process. So when to refer? So if you read American Thoracic Society or European Respiratory Society guidelines, they'd say vaguely, here's where you think about it, and it's on this left block. If you have a patient with gold stage C or D, can I see every single gold C and D patient? No, we'd be overrun with just COPD patients. But if they're having more than one exacerbation a year, it might be worth thinking about. Okay? If they're having atypical symptoms, it might be worth thinking about. So difficult to control symptoms, gold C or D, or frequent exacerbations. That's kind of just the general, here's when you refer a COPD patient. Other symptoms and other signs to be thinking about that, if there's some diagnostic uncertainty, and to potentially exclude asthma, some of the more subtle spirometry maneuvers that we might be able to do in our clinic, methacholine challenge, how well are you going to do a bronchodilator response, that kind of stuff. Unusual symptoms like hemoptysis, if you have a rapid decline in lung function or FEV1, if you suspect severe COPD. I would say that any patient that you categorize as a D, it's probably worth thinking about getting at least one consult from the pulmonologist. If you have the onset of cor pulmonale, this is a little bit tricky. We see a lot of folks just for home oxygen therapy and home oxygen titrations. I think that's okay right now, but I do think that there's going to be a role for sort of helping to give the primary care clinics the tools and resources to do that. So assessing need for pulmonary rehab, we have a little bit more time with these folks than you guys do. Bullous lung disease, COPD that's precocious, assessment for lung transplantation, that's pretty obvious, or lung volume reduction surgery. Frequent chest exacerbations, that's a sign that there may be a bronchiectatic component that's more, that's more prominent, or there's, MAI disease or resistant Pseudomonas that's happening. And dysfunctional breathing, I guess I don't know what that means actually, because all these people have dysfunctional breathing. So here's the template that we've put together for CareOregon, and we haven't really rolled this out because if and when we do roll this out, and Tanya, chime in, there needs to be a way to do it that's not overwhelming for the primary care doc. But we'd like to work towards this because I think it will help you as the front line understand, well, what's an appropriate or inappropriate referral and why is it that I'm referring, and it'll help us understand what is it that we need to be focused on to help this patient, okay? So, do they have a history of smoking? Yes or no? Have they had an exacerbation over the last year? Yes or no? Was it outpatient, and how many? Was it an ED visit or hospitalization, and how many? So this is gold. This is gold criteria right here. This is how you diagnose, okay? Does the patient have dyspnea? Yes or no? Can they walk greater than 100 meters without stopping due to dyspnea? That's sort of a way to ask an MMRC question, okay? Have they had spirometry performed within the last year? Yes or no? Are they on a long-acting inhaler? Yes or no? And has the patient had a chest x-ray in the last year? I don't know that that's as important, but if you're having atypical symptoms, it's worth thinking about. We haven't talked about chest x-rays at all, but in patients with frequent mucus production that's changing in consistency or volume, it's probably worthwhile, especially if they're having any other extra pulmonary symptoms along with that, or if they have other comorbidities. It's something we're thinking about. So pretty straightforward, shouldn't take a lot of time, but anything that you add onto the onto the plate of the primary care provider is extra time. Believe me, I know that. Review. Okay, good. You can't diagnose without a spirometry. You have to have airflow obstruction. We've talked at the break, a few of us have, about how do we start to focus on getting primary care offices trained and retrained and tooled with the resources needed to do spirometry. I think we can come up with some ways to do that, so that'll be another focus over the next year or two for all of your clinics, I think. You have to have spirometry to diagnose. We need to know what symptoms you have. We need to know your risk factor, i.e. smoking, how often you're having exacerbations, and what are your comorbidities. More review. This is if anything else that you put on your bulletin board next to your computer, it will be this and the next slide, okay? So to review, we're going to categorize all COPD patients into A, B, C, or D. And first of all, you're going to look at their spirometry to help you categorize into A, B versus C, D, okay? You're going to look at their exacerbation history to categorize into A, B versus C, D, okay? You're going to look at their dyspnea or their symptom scores to categorize between A versus B or C versus D, okay? And shouldn't take a lot of time, and once you've got that class B patient, you can easily see when they're getting worse by saying, oh my gosh, look, you know, they've had one more exacerbation, they're now a C. I got to think about doing something about treatment. Do I need to get them to see the pulmonologist? What is it that I'm missing? And then finally, our COPD treatment pathway to review. For those patients with mild disease, it's a short-acting bronchodilator, albuterol. For those with Class B, which is moderate disease that are having infrequent exacerbations or aren't that, quote, symptomatic, it's either a LAMA or a LABA. For those with Class C, it's LAMA plus LABA, and D, LAMA plus LABA plus inhaled corticosteroid if there's not a contraindication to that, and to start thinking outside of the box at Class C and D, what other treatment modalities do I need to be introducing? Pulmonary rehab? Do I think about sending to the pulmonologist? You know, do I call them and ask, do I start azithromycin? You know, what is it that I'm missing? Okay. Oh, we had that one slide taken out. That's okay. So I had a cigarette with a big, you know.
Oh, I think it's
there we go. Okay. So the other thing besides, you know, the GOLD criteria and the COPD treatment pathway that I have on your bulletin board is a reminder that if you don't address the cigarette smoking, you're doing an injustice to the patient. Okay. It's important to address this every single time they come into office. It doesn't matter if they get angry or upset. It's that repetition. It's the behavioral component that is important. And then think about the pharmacotherapies that you have in your armamentarium to give that patient that's now willing to quit. And that's it. Questions?
Any burning questions?
I just have a really quick question. What does the CareOregon home respiratory therapy visits, is that something that we should kind of know a little bit about and why it's useful? How to sell it to patients?
Well, they're not buyers. They don't want that to happen.
Great. So we at CareOregon are very, very aware of the need to really wrap around our COPD patients, and we're trying to figure out how to best do that, right? So I've been at CareOregon for 6 years, and we have changed the way that we've supported these patients through that time. We spent the last year developing a pilot program to support COPD patients specifically, and we have just finished that year of data gathering. So we can figure out how best to use my services. In the beginning, everything was a home visit. That's not really financially feasible for anyone to do all home visits on COPD patients. You know, we can't do that necessarily, so what can we do? And we're figuring that out right now. So for right now, the short answer is, if you have a patient with COPD that you think needs to be seen, that needs a closer look, we have a team of people that are looking at our COPD patients now. We have pharmacy and respiratory therapy are closely involved in this process, and we are going to be coming out with more specific information about how we can help this population.
I think the other way to think about that is the folks that are at the very far end of the spectrum of utilization. You know, those that are going to the ED 6 to 12 times a year, being hospitalized, 3 to 6 times a year. You know, what is it that that patient is not getting? I mean, those are worth direct phone calls to try to engage all of the provider team. You know, whatever we can to pull out all the stops on that patient population, because their mortality is off the charts.
I have one more quick thing before I forget to say it. On the last slide of my presentation, I think you guys have all the PowerPoints. There is a link to the COPD Gold website because everything we've talked about today is from that website, and there's no way you're going to remember all of this. So their website is very user-friendly. There's a section for providers. There's a whole section with the entire Gold guidelines, 155 pages. If you're interested, it's actually really interesting. It really is. And there's also a patient handout there that you could print off that we put a link to. It's a little bit long, but if you think that would be helpful.
Yeah, this is just concerning the referral to the pulmonologist. I think you had a category, you said MAI. What did that refer to?
Mycobacterium avium intracellular.
Okay.
So that's a chronic infectious process that a lot of these patients can be colonized with. It's a little bit difficult to diagnose, and it's a little bit of a challenge to treat when you get that point. Tanya.
I just wanted to add in for those of you at clinics who have clinical pharmacists as part of your team, make sure you're using them. If you have behavioral health as part of your team, make sure you're using them. At CareOregon, we've pulled together our, I'm medical director for Metro Area, in case you're wondering. My name's Tanya Kapka. We've also drafted an electronic referral that incorporates some of the elements that Dr. Cummings covered. And if you'd like us to share it with you, we would be thrilled to do so. In addition to that, we're continuing to develop efforts to do better sort of bidirectional electronic sharing. Additionally, a number of your clinics are getting onto the Rubicon MD platform. I would encourage you to use that for some of these patients to have the really nicely packaged thought through referrals. I know that when the Oregon Clinic gets referrals that have already gone through an electronic referral process, a lot of those patients are a little bit better prepared for that really high impact consult, and that can also help you develop your treatment plans before or as you're continuing to manage these patients.
And I can also tell you that we're still in negotiation with Rubicon ourselves to be on that platform and to be directed for those questions that are local, be directed to our clinic. So there'll be, a bit more of a personalization to it.
I also just wanted to follow up on your palliative care thing that you said earlier, and I also work for CareOregon, but just so that you were aware, we actually have a CareOregon only program through House Call called the Advanced Illness Care Team. So it's a community-based palliative care program, essentially, that has a nurse and a social worker. They also have spiritual care. And this population would fit into that, and it's only for CareOregon. And so they would stay with their primary care provider, and they would be in the community doing that wraparound care, helping with whatever the identified needs are. So that's just another resource to consider if you're thinking more on the advanced illness side of this.
Thank you.
It's called the ACE program, but the Advanced Illness Care Team, and it's through House Call providers. The referral's also on CareOregon's website as a referral, so you can go to the provider page into referrals and look for House Call. And the referral will be it's a referral for all House Call programs, so you can just check the ACE program. Or if you're like, I actually don't know, then they'll just get back to you. So that referral page is on our website.
I just have a piggyback. Kind of shameless plug. I would say maybe also consider CareOregon has a really robust care coordination team that can be a resource and a liaison. Not always necessarily disease specific, but we have our health resiliency, our community-based folks, our transitional care team, our office-based care team that often act as a liaison between these multiple different resources and kind of helping bring it all together or, kind of help frame where to put our energy. So just, a consideration that we're also a resource.
Outstanding.
Great.
Everyone, please do me a favor and express your thanks to all of our fantastic presenters that we had here today. They've worked really hard putting this together for you.